Yeah, Sujata.
Yes, sir. Good
Yes,
morning,
yes.
everybody.
Now we can hear you. Yes.
Good morning, Kapil
Morning,
sir. Good
morning.
morning, everybody. So we are continuing last Saturday discuss case of G junction tumor. So in short, I will summarize. One 67-year-old male with no known comorbidities came with chief complaint of dysphagia since 1 and a half months. It was insidious onset, gradually progressive from solid to liquids. Grade 4 dysphagia with intermittent food getting stuck at the lower chest. He also gave history of significant weight loss, around 5% of body weight over a period of 1 month, with loss of appetite. And there was no significant family history of any malignancy and no personal history of any addiction. Patient was well hydrated, moderately built, nourished. BMI was 25.8 kg per meter square. Performance status ECOG 1. Patient was hemodynamically stable with normal general and systemic examination. So we did upper GI scopy and it showed ulceroproliferative growth at OG junction extending to lesser and greater curvature, suggestive of CVD type 2. Biopsy suggestive of poorly differentiated adenocarcinoma grade 3. And last time we discussed about the CT scan. The so Pico angle was less than 45, so involvement of aorta was not there, and there were peri- uh, diffuse wall thickening was seen at OG junction and cardio of stomach, extending to proximal body along lesser and greater curvature of the stomach for length of 10 to 12 centimeter and maximum thickness of 2 centimeter, with multiple enlarged lymph nodes along the lesser curvature and greater curvature and para-aortic and aortocaval region.
Yeah, go CT again.
May I make a comment, sir? Hello?
So I'm Rajan. What?
It is type 3.
Yeah, I thought it's type 3. Rajan, what
Type
is your
3.
opinion?
Type 3. More
Yeah.
concerned about the thickening of the stomach so far. Could it be linitis plastica of the stomach and it is just involving the esophagus? Because that's how it looks like.
Yes.
The important thing is when there is
So,
obstruction at the
Sujata,
G
what Dr.
junction.
Yes, sir.
The thing is when there is obstruction at the G junction, it's very difficult to cause a distension of the entire stomach with the neutral contrast. So it may appear thick, but might not actually be thick in reality. So obvious thickness and transitioning, if it is seen, then of course there is a.
And although ideally the stomach should be fully distended to evaluate the wall thickness, but even if it is not distended, lower cuts, the coronal sections, you see the proximal stomach is thickened, the distal half of the stomach is not thickened. So which means it is, even if it is, this one, the fourth one on the bottom line. Yes, see the greater curvature of the distal part of that is the normal thickness.
Yes,
but
sir.
See the proximal greater curvature and the fundus and some part of lesser. And as we last time, the SIVA classification based on the epicenter. Now look at all the films that we have. The epicenter of them seems to be in the stomach, in the esophagus.
Can you show the endoscopic images if you have?
Yes, sir.
Show the endoscopy images.
Sir, these 4 images are only there, sir.
This is a poor quality endoscopic image. Actually, what happens is when there is a thickening at the G junction, immediately the endoscope starts thinking into THG region. So that is the mistake which has happened in your case also, which is extending into the G junction. It is not the G junction extending into the stomach.
And also, when you have a diffuse thickening of the stomach like this, what Dr. Rajendra was saying, two things should immediately come to your mind. Spastica, then confined to one part of stomach, not necessary that the whole stomach has to be involved. And second is the lymphoma. Whenever you have a diffuse thickening of the wall of a viscus, which is not distending well, either with oral fluid or on endoscopic insufflation, and if your biopsy is negative, I think we
Sir, your voice is not clear, sir. Kapoor, sir, your voice is not clear.
It's breaking up, sir. Another thing to realize in this importance is if you see a growth at the G junction, which is at the lower part of the esophagus, most probably the abdominal part, because I can't see any images with the Zenker line. There's no Zenker line visible anywhere. So it appears to be involving the distal esophagus. And this linitis plastica sort of thickness, there is a limited linitis plastica, it's called, that is extending about 3 to 4 centimeters from the G junction.
Yes, sir.
So
Okay,
the
so let us
epicenter will be somewhere in the fundus of the stomach. So that should be considered the diagnosis, type 3.
Yes, sir.
so let us presume that this is a type 3 G junction first, then we will come to type 2 later. What is your plan of management?
Sir, I will do staging lab, and if there are no metastasis, to
What is the
assess
role
the
of staging laparoscopy? What is the role of staging laparoscopy in adenocarcinoma of the G junction and of the stomach?
sir, usually we do staging lab for proximal gastric cancer and G junction tumor to assess the metastasis. If there are no metastasis, we can go for perioperative chemotherapy. And if there are metastasis, then we have to go for palliative chemotherapy.
I didn't ask you whether you do it or not. I asked you what is the role. So you have to tell me the information from the literature. What you told me is your practice. I didn't ask you that. So
Yes,
you
sir.
must always listen to the question and answer what has been asked. So
Yes, sir.
repeat again. What is the role of staging laparoscopy in adenocarcinoma of the stomach?
Sir, for staging lab, we usually do staging lab to assess the metastasis. And for cytology.
That is the role of staging laparoscopy in general.
Yes,
I'm
sir.
asking what is its role in adenocarcinoma of the stomach? Do you do it in colon?
No,
Do you do
sir.
staging laparoscopy in CA colon? Do you do staging laparoscopy in colon?
Sir, usually we, even if it
What
is
is the hesitation? You don't do it as a routine,
yes,
isn't
sir.
it?
Yes, sir. Yes, sir.
But
We
we do it in
usually
stomach. So
yeah, sir. Because
why do we
if
do it?
so to
Yes.
assess the metastasis so that we can start either patient will go for palliative or patient
What
will
is
go
the
for
percentage of individuals who have endoscopy in carcinoma stomach staged by CT scan have positive peritoneal deposits versus a normal peritoneal cavity in CA stomach? That's what sir is asking you in other words. Does it make a difference in management? What is the particular number
yes,
of
sir.
patients who are not going to undergo further surgery if you find deposits?
Around 6 to 20% of patient will have change in management of treatment. There are metastatic. So actually, exact number I am sure.
20% is a figure. about 20% of patients you can get metastasis and also see serosal involvement of the carcinoma of the stomach. If either of these things are there, you won't proceed with resection. You will proceed with chemotherapy for a period. Previously, it used to be chemoradiotherapy, but then with the MAGIC trial, chemoradiotherapy has been given up. We are doing only chemotherapy.
Yes, sir.
Even if you don't know the percentage, your answer should be that as opposed to CA colon, which is a low aggressive biology tumor, CA stomach is an aggressive biology tumor. Chances of CA stomach metastasizing in the peritoneal cavity are higher than in colon, number one. Number two, in CA colon, even if we find peritoneal metastasis, unless it is extensive peritoneal dissemination, and if the primary tumor is resectable, we will still resect it. Whereas, and in CA colon, there is a role for even cytoreductive surgery and HIPEC, even in presence of extensive peritoneal metastasis. That's a separate topic. Versus CA stomach, where if you find peritoneal dissemination, and same holds true for HPV malignancies also, you will not proceed with resection. So these are the two reasons why staging laparoscopy is recommended and done by most centers in aggressive biology tumors, which includes HCC, which includes gallbladder cancer, which includes pancreatic head cancer, which includes CS stomach, which some people say would include even adenocarcinoma of the GE junction, as opposed to CA colorectum, where it is not routinely done. It may be done in selective cases where there is a high suspicion. So that is the difference. And then if you know the exact number, as Dr. Desai said, 20%, around 20%, that is fine. Because in CS stomach, if you see a peritoneal or omental deposit, you will not proceed with resection.
Sujata, anything between a CT scan, endoscopy, and diagnostic lab or a staging lab? Anything in between you would like to do?
PET scan.
Before surgery? Any more investigation? You have got a CT scan done, endoscopy done, biopsy done.
We'll do PET scan, baseline PET scan. And secondly, we will do MSI.
So you have done a PET scan. Now, what is the role of a PET scan followed by a staging lab? What is the thing that you are likely to miss on a PET scan, which will be seen only on a staging lab?
So on
PET scan you have done means that yes.
On staging lab, around less than 5 mm metastatic deposit on peritoneum, which we miss out in PET scan, will be seen on staging lab. So if it is present, we will go for the palliative therapy. If not, then we will go for perioperative chemotherapy.
So PET scan, I would say it has a role. It will show you the primary lesion if it is T3 and beyond. If it is having multiple nodes which are having a PET uptake, they will both indicate a neoadjuvant therapy anyway and helps in follow-up after the neoadjuvant. And if it already shows a disseminated disease in liver, then it is already a stage 4 disease. In that, the therapy will not be neoadjuvant. It will be a palliative chemotherapy. In either of the three circumstances, you will not require staging laparoscopy. Staging laparoscopy will be required once you have given a neoadjuvant or you are intending to do a resection directly, upfront surgery, which is almost obsolete nowadays.
Is there a problem with PET scan? Is there an issue?
Sir, can you repeat the question, sir?
Is there a problem? Is there an issue with PET scan in CS stomach, particularly?
Sir, CS stomach usually it is not FDG avid, but especially distal tumors are not FDG avid. So poorly differentiated mucinous signet ring.
Yeah, so mucin secreting tumors, signet ring cell tumors, they are not FDG avid. So PET scan may be false negative. There may be a metastasis, but it is not. But if it is seen, it is definitely there. So that is the advantage. Okay. Any issue with PET scan in general, especially in our patients? in any malignancy, is there any problem with PET scan, especially in Indian patients? Any disease which can cause a
TB,
diagnostic dilemma? Yeah.
TB is there, inflammatory.
You can have coincidental tuberculosis, especially in the nodes, and they will also be FDG avid. So you don't know whether the node is really metastatic or it is a coincidental TB. So you have to keep that in mind. And most groups say that in our patients, before you condemn a patient based on PET scan alone, you should try to get a positive tissue diagnosis before you say that it is metastatic. Okay, so
Yes,
we
sir.
have done a staging laparoscopy and it doesn't show any dissemination. Then what?
Sir, we will
In
go
this
for
case,
perioperative chemotherapy, ECF regimen, 3 cycles, and after 3 cycles, we will do after a period of 6 to 8 weeks, we will do repeat PET scan and assess whether there is a response to the chemotherapy, any shrinkage in the size of the tumor, or any reduced FDG uptake in the lymph nodes. And then, if it show good response, then we will proceed for staging lab after a period of 6 to 8 weeks.
why you want to give neoadjuvant treatment? Why
This is,
surgery? You said that there is no aortic involvement.
sir,
Is it a resectable tumor or is it an unresectable tumor
it is a
on CT?
resectable tumor, T2 plus with N plus. So in such bulky tumors, we should first give perioperative chemotherapy. A multimodality treatment should be followed for such cases. So first we will give 3 cycles of ECF regimen, and then we will assess the patient with PET scan, and
Don't
then we will.
repeat what you have already said. You already said this. Question is that even if it is a resectable tumor, why do you want to give neoadjuvant treatment? Why not upfront surgery?
We can assess the tumor biology first, and it will treat the micrometastasis, and the study shows that the risk of local recurrence is less, and R0 resection rate is high.
So you should enumerate. Now, this is a theoretical question. You should show your knowledge. There is a treatment if the tumor is unresectable or doubtfully resectable. Then you can convert it into a resectable tumor. But even for resectable tumors, where there is no contraindication for resection, in locally advanced tumors, which is T2 plus and node positive in the stomach and many other places, now it has been shown that neoadjuvant treatment has a role by decreasing the risk of local recurrence, in some cases by even improving the survival. And the hypothesis is that it takes care of the micrometastasis, which may be present, and some people feel they are almost always present in patients with locally advanced tumor. And in a situation like rectum, it sterilizes the circumferential resection margin. So these are all the advantages of neoadjuvant treatment. What are the disadvantages?
We are unnecessarily waiting for a long period of time when the tumor is not responsive to chemotherapy, and by the time the patient completes 3 cycles, the tumor become unresectable. So this is one disadvantage. Second, sometimes the chemotherapy will have adverse effect on the patient, and it will reduce the performance status. And many a times, few patients are unable to go for surgery after chemotherapy, and there are chances because of adverse effect there is mortality in between.
Good. So one is that serious grade 3 or grade 4 adverse event, which decreases the overall performance status of the patient and causes severe morbidity, may even cause mortality. And second is that the tumor grows while on a neoadjuvant treatment, and from resectable, it becomes unresectable, where point of view, it is a problem because the patient may come back to you and say that if you had done the surgery earlier, it was a resectable tumor. But you have to understand and you have to explain to the patient that in such a situation where the tumor has either progressed or metastasized, even on neoadjuvant treatment, the outcome, even if resection was done, would be poor. So you select out good response cases who are expected to have better survival. That is also an advantage, that those who do not respond, you don't operate on them because they are going to have a poor outcome anyway. So overall, your results of resection improve because then you are resecting only the good biology, good response cases. So these are points for and against neoadjuvant treatment. Now you chose ECF regimen. What protocol is that?
So epirubicin, cisplatin, 5-FU, we give 3 cycles.
What is the name of that regime?
Magic trial.
Which study?
Magic trial. Is a European study, magic trial.
So as Dr. Desai was saying, is that the only option in adenocarcinoma of the GE junction or stomach, or is there something else?
Sir, there is FLOT regimen, ECF trial, and also we can give docetaxel, cisplatin 5-FU. In a FLOT regimen, we have 5-FU, docetaxel, ofloxacin, 5-FU.
FLOT is L for
leucovorin.
Leucovorin is what? Is it a chemotherapeutic agent?
No, sir. It is usually give along with the 5-FU for B6 deficiency to prevent the side effects of 5-FU. Usually 5-FU with leucovorin combination is given in all the regimen.
And O
For oxaliplatin and T for docetaxel.
yes. So without going into the details of dosages, what is the regime in ACF, ECF, and what is the regime in FLOT? How many cycles? When do you give them? What is it called?
Sir, it is a perioperative chemotherapy. In FLOT, we give 4 cycles preoperatively
What do you mean by what is meant by
neoadjuvant
yes,
4 cycles, and then after surgery, adjuvant 4 cycles for FLOT regimen. In ECF, we give 3 cycles as neoadjuvant, followed by surgery, and then 3 cycles as an adjuvant chemotherapy.
Yeah. So both these regimes are perioperative. You give 3 or 4 cycles before surgery, then you operate, and then you give the remaining 3 or 4 cycles after surgery. Now you said that you will give 3 cycles of ECF and reevaluate with a PET scan. So that is the only way to reevaluate after neoadjuvant treatment. How do you assess the response in any tumor after giving any neoadjuvant therapy?
So usually we assess clinically, radiologically, and before surgery we will do staging laparoscopy. Clinically, there will be improvement in dysphagia of the patient, and radiologically there will be reduced FDG. PET scan, it will be reduced FDG uptake. SUV max will be
PET
reduced.
PET scan is not radiology. Scan functional imaging.
So
the response is CT scan, endoscopically, histologically, you can do a biopsy, and biologically, which is PET scan. And in some situations like pancreas, biological response will also include tumor marker. So if you have done a pre-therapy tumor marker level, you can assess the tumor marker level. So you should give the complete answer. It is not only PET scan, it is clinical, radiological, endoscopic, histologic. In squamous cell carcinoma of the esophagus, if you are hoping for a complete response, you will have to document it with histology also. You have to do a biopsy. If you are following the Haber gamma regime in CA rectum, you have to document response both radiologically, biologically, and histologically. You have to do a biopsy and show that it is negative. Because if the biopsy is positive, you cannot obviously follow Haber gamma regime, isn't it?
yes, sir.
So there are several ways by which you can assess response to neoadjuvant treatment. You may or may not use all methods in all patients, but These are the options. Okay, so we have given 3 cycles. There is some response. Now, what will you do?
Sir, I will do staging laparoscopy.
Negative.
Then I will proceed for left thoracoabdominal incision or Ivor Lewis. I will do minimally invasive Ivor Lewis.
Ivor Lewis. Ivor Lewis is what? First,
Do you
tell us
want
what
to
is
do a
the
total gastrectomy or not?
I will do total gastrectomy.
Then where is the question of Ivor
procedure,
Lewis?
then tell the approach.
Sir, I will do total gastrectomy with proximal esophagectomy with 5 centimeter margin from the tumor, proximal margin, and I will do Roux-en-Y esophagojejunostomy with feeding jejunostomy, and anastomosis will be in thorax. After the excision of specimen, I will send the proximal margin for frozen section. If it is negative, then I will go for the anastomosis.
No. Oh.
What are the functional difficulties when you do an intrathoracic anastomosis? I'm not talking about leak and sepsis, which is separate, but as such, what are the problems when you do a esophagojejunostomy? Do you want to do a pouch or you don't want to do a pouch? How? And if you do a pouch, what is the disadvantage if you do it in the thorax?
Sir, usually there is a risk of regurgitation, high risk of GERD and dysphagia.
Okay. So what is your
Dumping
ideal
syndrome.
option now? So for your tumor, for this patient, what will you do?
Sir, usually we do esophagojejunostomy, but so we have at our institute we don't do pouch since
No,
jejuno
you
has a
already
good
said
option.
there is high incidence of GERD. I accept that answer. I didn't contradict you. That's what we wanted to know. The only problem is if it is not in the abdomen, part of the esophagus and the pouch, you are going to get a lot of reflux of food that is eaten and recurrent aspirations also. So we don't do a pouch if it is in the thorax, but if it is in the abdomen, we do a pouch.
Sir, can you
Kapoor,
repeat
sir?
question, sir? I
Hello, Kapoor, sir? They seem to have been cut off.
Sir, can you repeat the question? I couldn't get, sir. Last.
Just give me a second. I'm also having trouble with this. I don't think Kapoor sir is there online at the moment.
Sorry, we lost connection in between, Rajan. Sorry.
Yeah, that's
We are back. So, Sujata, whenever you are asked to describe the treatment of CA esophagus, CA G junction, or CA stomach, there are few things which have to come out in the first instance. One is what procedure you are planning. So as Dr. Rajan was saying, whether it is total gastrectomy with partial esophagectomy, whether it is total gastrectomy with subtotal esophagectomy and a cervical anastomosis, whether it is partial esophago, partial proximal gastrectomy with the esophagogastric anastomosis. So extent of esophageal resection and extent of gastric resection has to come in the nomenclature itself, number one. Number two, then you have to describe what approach. Number three, you have to describe where will your anastomosis be and what will be the conduit. So now let us go back to this case. What will be your planned operative procedure?
Sir, I will do total gastrectomy with partial esophagectomy with 5 centimeter proximal margin, and my conduit is jejunum, Roux-en-Y loop of jejunum with intrathoracic anastomosis with feeding jejunostomy.
Sorry, we could not hear you in between properly. So I would say, if you are considering to be, as we are considering, type 3 GE junction growth or even a CS stomach involving the GE junction, then the treatment, and because there is significant extension along the lesser curvature, which is more important than the greater curvature. Greater curvature, you have a great length. So that is not of much consequence. But if significant part of lesser curvature is involved, I think most people in this case would do a total gastrectomy with a partial esophagectomy with, of course, a frozen section of the proximal margin. You will try to get at least 5 centimeter proximal margin on the esophagus. And if the margin is negative, then it will end up with a infracarinal esophago-jejunal Roux-en-Y or a pouch that we'll come to later, intrathoracic anastomosis. And if you're doing an infracarinal anastomosis, it will be a left thoracoabdominal approach. Ivor-Lewis is, what is the Ivor-Lewis approach? What does it involve?
It is right thoracotomy we usually do.
Yeah, so Ivor-Lewis is right thoracotomy and
We do
laparotomy,
left thorac.
where the
Yeah.
anastomosis goes above the carina. Okay, or you could do a transhiatal and cervical anastomosis, or you could do a transthoracic and cervical anastomosis. So that depends on the philosophy. By and large, in adenocarcinoma, proximal, you need 5 centimeter margin. In squamous cell carcinoma, most people will go for 10 centimeter margin, which would invariably mean a subtotal. We call it total, but it is actually subtotal because you preserve the cervical esophagus with a cervical anastomosis. So whenever you are describing, you have to mention all these four things: the extent of resection, the approach which you are going to use, what conduit, and where the anastomosis will be sited. And then, of course, you can say whether you will do conventional open surgery or minimal invasive surgery. Rajan, what was your approach to this case?
What you said exactly, but I would do it on the left side. I would do a thoracoabdominal. I would do an esophagogastrectomy. Distal esophagus, minimum 5 centimeters of margin. Roux-en-Y loop reconstruction, no pouch because it's in the thorax. Pouches in the thorax often have a lot of reflux and cough and disturbance with function as well. With every breath, they regurgitate. So I won't do a pouch. What would be important is that the incidence of dehiscence of the anastomosis and leakage is actually lower in the thorax than in the neck. And neck and disadvantage would be that if you cannot use a Roux-en-Y loop of jejunum to the neck, you will have to do a colon bypass, which immensely increases the scope of the surgery. And preparing the colon also is difficult once there is an obstructing esophagogastric growth. You find emptying the colon and preparing the colon very difficult. So one should be prepared for a massive undertaking. And I don't think after 3 ECF or 4 flot, we would be able to have a patient with ECOG who can withstand such a massive operation.
So there will be some groups which, for a case like this, would do a total gastrectomy and a subtotal esophagectomy because they want to do the anastomosis in the neck. As Dr. Desai said, between a cervical and a thoracic anastomosis, the pros and cons are that leak rates are much more in cervical anastomosis as compared to thoracic anastomosis, but leaks in neck are usually not very serious, very dangerous, unless the leak trickles into the posterior mediastinum, whereas a thoracic anastomosis leak, the mortality will be higher.
Yes, sir.
Now, suppose it was a SIVA type 2, then what would be your approach?
Sir,
Okay, first
depending.
let me suppose it's SIVA type 1, then what will be your approach? SIVA type 1, and you should remember that SIVA classification is only for adenocarcinoma of the GE junction. If it is squamous cell carcinoma, SIVA classification does not apply. So SIVA type 1 adenocarcinoma GE junction, what is the treatment? After neoadjuvant treatment has been given, what is the surgical treatment?
SIVA type 1 is treated like esophageal cancer, and you will do subtotal esophagectomy with 5 centimeter proximal margin and stomach pull-up. But you have to also ensure that there is no involvement of stomach. The intrathoracic anastomosis.
So if there is involvement of, then
extent of lesser curve, but if it is involvement of stomach, it is usually as type 2 CVT. So the rule
so the
will be
answer
applied.
is SIVA type 1 is treated like status. Only difference is, as I said earlier, that while in squamous cell carcinoma, you need a 10 centimeter margin, which invariably takes the anastomosis either to very high in the left chest or in the neck. In adenocarcinoma, you need only 5 centimeter margin. So if depending on the build of the patient, suppose it is a tall built patient and the growth is at 38 centimeter, you may get away with a left thoracoabdominal incision only and doing an infracarinal anastomosis. But I think most people would do subtotal esophagectomy and do either a cervical or a high left intrathoracic of stomach resection. If stomach is not involved or very minimally involved, you just take out the kind of sleeve of the stomach, just as we do a sleeve gastrectomy, and use the gastric tube in conduit. So in those cases, the fundus is usually not involved, and the highest point of the gastric tube is the fundus. So it can easily reach even the neck if you want to do the anastomosis in the neck. So SIVA type 1 is treated like CA esophagus. You need at least 5 centimeter proximal margin. Preferably, you should do frozen section of the proximal margin. The stomach usually is either just a sleeve of the lesser curvature or a proximal partial gastrectomy. And stomach is available as a conduit, whether for a supracarinal intrathoracic anastomosis on the left side or a cervical anastomosis. Okay?
Yes, sir.
What about type 2?
So type 2 also will do left thoracoabdominal incision with the proximal extent of excision 5 centimeter above the tumor margin with intraoperative frozen section. Distally, we will see along the lesser curvature the extent of the growth, and we will do sleeve gastrectomy and pull with gastric pull-up. We'll create a long gastric tube with gastric pull-up and either intrathoracic or high cervical anastomosis.
Yeah, so type 2 is a debatable entity because there are approaches. There could be a conservative approach where somebody may do only a partial esophago proximal gastrectomy and do esophago gastric anastomosis in the chest, subcarinal or infracarinal, using a left thoracoabdominal approach. But with this approach, if the disease is fairly advanced, there is a risk that either your proximal or distal margin may be positive. On the other hand, you could have a very aggressive approach where some groups would do even a subtotal esophagectomy and even a total gastrectomy and use a colonic conduit to take to the neck. Dr. Thiathuravale, your microphone is on. Please mute yourself.
एक repeat USGF नहीं कराया मैंने.
Dr. Jiten, your microphone is on. Dr. Jiten Chauhan. Rajen, what is your approach to a type 2 CVERT?
Type 2 treated as a gastric lesion only. So what you suggested was a sleeve of the lesser curve. Depending on the lesser curve, how far the extension is, that would be decided. Give minimum of 3 centimeters margin from the growth on the lesser curve and the greater curve. Take off the proximal stomach and do a Ivor-Lewis type of anastomosis if the stomach can be pulled up after a thorough cauterization. I would do a thorough cauterization and then try to pull the stomach up. If on the other hand, if the stomach is not adequate as a conduit and it's not coming up into the chest, I would be very concerned of venous congestion of the stomach, which increases the risk of complications. Colon would be a possible conduit I would think of. I still prefer total gastrectomy.
So as we discussed, the extent of resection, the approach, the anastomosis, and then whether open or minimally invasive approaches. I'm sorry, I'll have to leave in between. Ajay will continue the session.
Thank you, sir.
Sure, sir.
Thank you, sir.
It has been a quite interesting discussion. Only thing is now, just to summarize what you have said is type 1, you will treat it as CA esophagus. Type 3 is CA stomach. And type 2, since it lies in between, most of the people still treat it as CA stomach. But you can have margins available on both the sides with type 2. I think that's what you want to conclude.
Yes, sir.
Am I correct, sir? Okay.
Yes,
So
sir.
now we discussed a lot about the proximal margin. As adenocarcinoma, you need to have 10 centimeters margin. Squamous cell carcinoma, you need to have 5 centimeters. But distal margin is also important.
Yes, sir. Distal
How do you
margin is
decide the
important.
distal margin for type 2 and specifically for type 2?
5
How
centimeters.
much?
5
Sir,
centimeters. From the lesser curve, 3 centimeters, and from the proximal growth, at least 3 to 5 centimeters. 3 centimeters is more sufficient.
So what Dr. Desai is saying is that the distal margin 3 centimeters is sufficient and preferably 5 centimeters. So I would add to that, for a type 1 tumor, whenever you have a type 1 tumor, your margin should be minimum 3 centimeters. But for a type 2 and type 3 lesions, you should have a 5 centimeters distal margin. For a type 3, since it is being treated as CS stomach, you will remove the entire stomach. You may do a total gastrectomy. So that 5 centimeters is already holding on. But for a type 2, now this 5 centimeters is more relevant because you may like to use stomach and the esophageal anastomosis to the chest. Am I clear, Sujata?
yes, sir.
So
Yes,
now
sir,
you
Dr.
told
Rajesh.
that we will do a left-sided abdominal incision. Is that correct?
Yes, sir. Left-sided thoracoabdominal incision with
That is the what the incision you were describing.
yes, sir.
So if suppose you want to do it by a minimal invasive approach, by a laparoscopic procedure, then will you like to do a chest first or abdomen first?
Abdomen first to create the conduit.
Yes, Dr.
Sir,
Desai. Sujata,
yes, sir. Usually,
we are having some
uh,
kind of problem with internet connection.
no, sir. No, sir.
Okay,
Sir, we'll do
fine. You may
laparoscopy,
continue.
mobilize the conduit, and then thoracoscopic mobilization of the tumor. We'll,
So you say you will first do a abdomen and then subsequently you do a the thoracic approach.
yes, sir.
Here, the thoracic approach will be
And for
left-sided or
type 1,
right-sided?
yes, sir. Yes, Dr. Desai.
Thank you, Ajay sir. Would you do a left thoracoscopic mobilization or a right thoracoscopic mobilization? Would
The
you
right
use would you use the prone position?
prone position with right right VATS we will do video assisted thoracoscopic surgery.
Yeah, sure.
Prone position.
Sir, what do you think, Ajay sir?
Sir, I am slightly of the different opinion. One thing is that since if in case we are dealing with a type 3 lesion, I think we have to do a first abdominal approach, mobilize the entire stomach. That is the first part with the lymph nodal clearance. And then you will make a conduit, and now you want to do anastomosis in the neck, in the chest. So now either you have to do a complete mobilization, make him in prone position, and then pull the jejunum into the chest. Or the easier method is in the same position, you may make it left lateral position. So nowadays, most of the people are going ahead with left lateral position. That makes the surgery relatively easier. And since you have done already the abdominal part, now rather than putting him in prone, most of the recommendations were of prone earlier. Now a lateral position has been now a preferred approach now.
Okay, sir. But most of the surgical surgical oncologists are doing what I said.
So we at our institute usually give prone position
doing?
and do the prone position with thoracoscopic mobilization of the tumor and then proceed with laparotomy and mobilize the conduit and
Yes,
then
I
the
agree, Sujata.
anastomosis in cervical region.
I agree with Sujata and Dr. Desai that what we are still following is a prone position. Even we at our institute follow a prone position, but the entire literature is now going towards the lateral position now. Now the prone position as compared to lateral position, the lateral position is more preferred position.
Sure, sir. Understand that.
Right? One thing is because with a similar supine position, with a slight tilt, you can make it a lateral position. And for a prone, you have to completely tilt the patient, and then you have to de-scrub and re-scrub again.
Yeah.
For a lateral position, you can plan it before the surgery and just orient the patient and make it a left lateral position at the same setting. So that makes a slight difference in the positioning and makes the surgery easier. That is what the recommendation. And second thing, since you have done it the abdominal part first, you have done a gastrectomy, you have done a division at the duodenum, and then made a loop of jejunum prior to doing the thorax part. So now the only part left is the thoracic part, which if you make it prone and if you miss a loop into the jejunum, it may be difficult to identify from the thoracic approach in a prone position.
Yes, sir.
The literature earlier was what Dr. Kapoor was saying, that all the anastomosis was with a total esophagectomy with anastomosis in the neck. This was till 2 years back. Now the last 2 years, all the literature coming up is now the anastomosis in the chest. Even for type 1, what I recently read was a partial esophagectomy and anastomosis in the chest and above the carina. That's what Dr. Kapoor was mentioning. It was the same paper which we had seen. And then subsequently for type 2, it may be
Sir, your voice is breaking, sir.
below the with the 5 centimeter.
Sir, your voice is breaking up.
Some. Yes, Dr. Rajendra.
No, your voice is breaking up, sir. That's we're not able to hear what you said for the last 2 minutes. You said I have read recently a report or something. Hello, Ajay sir?
Yes, actually, we lost the connection. Now we are again back. Yes, sir, please.
Yeah. No, you are telling us something, so I was listening.
Yeah, I was telling that with the prone position, it becomes more difficult as compared to the lateral position. So most of the literature is going after. In last 2 years, lot of literature has come onto the anastomosis in the chest. The leak rates in the chest have been shown to be lesser than the leak rate in the neck, though the leak in the neck is less harmful than the leak in the chest. The chest leak is very harmful. So that is why when it began, it was all anastomosis in the neck. Now the anastomosis is in the chest. In last 2 years, it has developed. Therefore, the positioning is also the original position, which was a prone position described by Dr. Dr. Palani Velu. It was described by Dr. Palani Velu. It has now been less commonly used, and a lateral position is more commonly used because of the intrathoracic anastomosis being preferred nowadays. The prone position was good when you are doing first the chest part. You mobilize the entire esophagus. You mobilize for a G junction tumor or for a CA esophagus. You do the entire lymph nodal clearance and then make a conduit of stomach and take it into the neck. So that is how the for a prone position it was being recommended. But then subsequently for G junction tumors, it is now the lateral position which is more recommended. First, doing the abdominal part is more important because you will have to see the peritoneal metastasis and the liver metastasis, which are missed on PET scan, and then which you will find on diagnostic lab. So it is the abdominal approach which is more important nowadays. First abdominal approach.
Yes, sir.
Anything else you would like to add, Dr. Desai?
Thank you, sir. Thank you, sir. Perfect. Just what I think. One more thing. What are the lymph nodes you remove in each type?
Sir,
Yeah,
in,
nodal
And why?
clearance, Sujata.
sir, usually in India, we prefer two-field lymph node dissection rather than three-field, which is followed in Japan. So we do abdominal along the celiac plexus, along the celiac artery, left gastric, splenic, and common hepatic artery. We along the lesser curvature, we drain the lymph nodes, and in thoracic part, we do mediastinal lymph node dissection, paraesophageal,
What about
infracranial.
the abdominal? What about the abdominal dissection in Sievert's type 2 and 3? What abdominal lymph nodes would you like to remove? It is different from CA esophagus or CA stomach. Would you remove para-aortic lymph nodes between the aorta, left border of the aorta and the renal artery?
Sir, usually,
Because distal esophagus and proximal stomach have remnants of the mesentery, dorsal mesentery. And because of this dorsal mesentery and the lymphatics draining through that area, you get this area described by Sievert, where the lymph nodes along between the left border of aorta and the renal artery are all completely removed. Along with the specimen, you do an en bloc resection and remove it. While in type 3, which is like total gastrectomy, you do the same as gastric lymphadenectomy, D2 dissection. Sir, it is breaking up.
I think you could get
Sir, your voice is breaking up. We can't hear you since the last 3 minutes. Is there anything else you wanted to add, Sujata?
Yes, sir. Thoracic region, we will do lower mediastinal lymph node dissection.
Yeah, 104 and
Lacarina.
105.
Yeah, sorry, actually we lost the connection. So we have to
Yeah.
reconnect it through the other mode. So, Sujata, I think I'll just repeat the question. What is the lymph nodal clearance difference between the type 2 and type 3 G junction tumor? That was what Dr. Desai was emphasizing on.
Yes, sir. As sir has mentioned, for type 2, we will do sievert area lymph node dissection along the left side of aorta and the left renal artery, the celiac artery, left gastric and splenic artery lymph node dissection. For type 3, we usually follow the D2 distal gastrectomy protocol. And in mediastinum, we will dissect the lower mediastinal lymph nodes, paraesophageal, infracarinal.
Fine, fair enough. I think that has been very well said, Sujata. I think that's what Dr. Desai was emphasizing. For a type 2 and type 3, it is not the same lymph nodal clearance. For a type 3, it is like a CS stomach. One more question, Sujata. What is the timing of your surgery compared to your completion of chemotherapy?
After completion of chemotherapy, we will wait for 6 to 8 weeks and then we will reassess PET scan, then followed by staging lab.
You will usually get a patient, the patient is getting a chemotherapy every 3 weekly. And once he comes for a third week, after third week of the last fourth cycle, the oncologist will get a PET scan done to see if they want to give a cycle subsequently to it or not. So at third week, the patient is usually having a PET scan done, and then he will be referred back to you. You will get a new PET scan prior to surgery, wait for 3 more weeks, do it surgery immediately.
Sir, usually after last chemo, we will wait for 4 to 6 weeks. Last chemo completion.
So I wait, and even if you have to delay the chemotherapy this cycle, it is not harmful.
Sir,
in case it comes out to be advanced disease, they may have to continue with the chemotherapy.
Yes, sir.
But because the chemotherapy has to be given at the end of third week, so they will get a PET scan done at the third week. We need to delay the PET scan because the timing between the PET scan and the surgery need to match. We can't do a surgery after 3 weeks of a PET scan.
Okay, sir. Sir, I didn't get to the last sentence which you can you give a more complete answer, sir, for the last sentence you have said.
Sujata, sorry, can you repeat, please?
Sir, can you tell the last line which you have said?
Yeah, what I said was normally an oncologist, they give the cycle at third week or fourth, usually third week, 3 weekly cycle. So when the patient comes for a follow-up, after the 4 cycles of chemotherapy, they will get a PET scan done. And when the PET scan shows a reasonable resolution or non-progression of the disease, then they will refer the patient for surgery. So this is 3 weeks after the chemotherapy. We prefer a surgery at 6 weeks after the chemotherapy. So there is a lag period between the PET scan done, which is at 3 weeks after the chemotherapy, and our planning of surgery at 6 weeks after the chemotherapy. So there is a lag period of 3 weeks. So
Yes,
we
sir.
can't depend upon a PET scan which has been done 3 weeks back, because in these 3 weeks the disease may progress because the patient is not getting a chemotherapy. So we always advised our oncologist, after your 4 cycles of chemotherapy, rather than getting a PET scan at 3 weeks, get a PET scan preferably at more than 4 weeks, at 5 weeks, so that the lag between our surgery and PET scan should not be very long.
Yes, sir.
For
Thank you.
that, they may have to rearrange their cycle of 5th cycle of chemotherapy. Dr. Desai, would you like to comment on that?
Perfectly, sir. Because oncologists are more and more veering towards preoperative chemotherapy in all GI tumors.
Yes, I think all except for colon and small bowel, rest everything has gone into a neoadjuvant protocol.
Yeah, more.
CAGB is also now coming on to a neoadjuvant protocol nowadays.
Yeah, I know. Sir,
So
time is 10:06.
yes.
Can we conclude?
So I think, yes, thank you. I think we can conclude. Thanks, Sujata, for a nice presentation. Thanks, Dr. Desai, and thanks for all the students who have participated in this.
Thank you,
Thank you,
Ajay,
sir.
sir.
Good presentation.
Thank you, sir.
Thank you. Thank you.